All right, we're going to go ahead and begin now. So thank you all for coming. My name is Wallace Dixon, and I'm director of the ETSU Ballot Health Strong Brain Institute. In the Strong Brain Institute, which is funded through a generous 5-year gift from Ballot Health, we strive to be the preferred resource for promoting the awareness and empirical study of adverse childhood experiences, for promoting the development and dissemination of evidence-based practices that prevent, reduce, or mitigate the negative effects of ACEs on health and health disparities, and for promoting a trauma-informed citizenry and workforce in the Appalachian Highlands region and beyond. In the Strong Brain Institute, we are very well aware that the work of preventing and mitigating ACEs lands in a large variety of physical, health, and social domains. In today's presentation, we will be focusing on one health outcome often associated with ACE histories, namely obesity. Today's presenter is Dr. Hannah Lawman. Today's presenter, Dr. Hannah Lawman, is an obesity medical liaison in medical affairs at Novo Nordisk. She has an extensive background in public health policy, research, caring for people with obesity, and supporting underserved populations. Hannah has an established health research career, including over 50 scientific publications and numerous research projects funded by NIH, CDC, and philanthropic organizations. Hannah attended ETSU as an undergraduate in psychology. And I'll have to say, I first got to meet Hannah when she worked in my lab in 2006-ish. So we've known each other for a very long time. And I was very excited to have the opportunity to bring her here. She received her PhD from the University of South Carolina and completed her clinical internship and postdoc in clinical health psychology at Temple University in Philadelphia. Hannah transitioned into public health and conducted epidemiological obesity research at the CDC with the National Health and Nutrition Examination Survey, or NHANES, and served in Sierra Leone on the 2014 Ebola emergency response. Hannah then joined the Philadelphia Department of Public Health as the Director of Research and Evaluation in the Division of Chronic Disease Prevention, where she led a team working on implementation and evaluation of policies to prevent obesity and promote healthy environments. During the pandemic, she served Philadelphia as Chief of Operations in the COVID Containment Division, where she helped lead the COVID-19 emergency response, a team of over 100 contract tracers and Philadelphia's Afghan refugee response. So at this point, I will hand it off to Hannah.
Thank you all so much for having me. It's really lovely to be back. It's been many, many years since I've been to ETSU's campus, and wonderful to see how much it has grown. Special thank you to Dr. Dixon, who helped spark my passion for research and education, and so grateful that we've been able to stay in contact all of these years. So today I will be talking about obesity, especially weight bias, and then different options around obesity treatment. And all of this, of course, is within the backdrop that this is Thanksgiving week. So it might seem like an odd topic for the week of Thanksgiving, but hopefully it leaves us in a place where we're feeling comfortable and free from stigma when we are breaking for Thanksgiving. I do have to make this disclosure that I'm presenting at the request of the Strong Brain Institute. And even though I'm an employee of Novo Nordisk, I'm here on my own time. So I will, I'm not, the views that I'm presenting today are not attributed to Novo Nordisk. So I want to start with a framework for how we're going to go through this journey of obesity. And I think a lot of times when people hear the word obesity, they think of something very simple. They think of a balance of calories in and calories out. There's a lot of stigma attached to people's weight. And so I want to start by, right off the bat, saying obesity is extremely complex and it can't really be reduced. It's not that historical perspective of simply balancing energy in and energy out. And this slide has several different levels of influences related to obesity. And you can think about this with many other health behaviors as well, or disease conditions. You can think of Bronfenbrenner's ecological model, which is where you see some of these factors coming in. So of course, there's biological factors related to obesity. There's our genetic predisposition, and we know that genes can account for 50 to 70% of the heritability in someone's weight. So there's a lot of those underlying biological factors, as well as differences in how our brain regulates appetite. And we're going to get a little bit more into that. Of course, there are lifestyle patterns that happen at the individual level. So this means what are those healthy habits or challenges with those healthy habits? And those are individual level factors, as well as the different treatments that one may or may not receive if they have the condition of obesity. Those are individual level factors. And then of course you take a step out, because all of those things are influenced by our environments, our workplaces, our schools, the policies that they have, the quality of care that they receive from their doctors, the norms in their family and relationships in families, as well as what's typical among your peers, those social factors. And stepping out even further, do you have a healthy built environment, available safe streets and safe playgrounds that you're able to be physically active in, as well as grocery stores or other healthy foods that are easy to get, or oftentimes what I have studied in Philadelphia, the reverse concept called a food swamp, where you may have healthy foods around you, but what's more likely is you're just overwhelmed with all of the delicious, tasty, cheap foods that kind of overwhelm a lot of those healthier options. And of course, local policies. I'll be talking about one example today from Philadelphia. And stepping back even more, thinking about the societal norms in our culture and other broader factors. So obesity is not simple, it's very complex. And that's really gonna frame a lot of the talk today. And you can see in the background of this slide, the foresight map, and this came from the UK, and it's known for suggesting that there's over 300 inputs related to the development of obesity. And that's where you see all those arrows in the background. So very, very complex. So before we dig more into it, let's set the stage a little bit with some basics. And so you can see here the prevalence of excess weight. And if you look at BMI over 25, and BMI is your weight in relation to your height, almost 75% of American adults have excess weight according to BMI. And once you reach a BMI of 30, that's where you have the medical condition that is known as having obesity. And we have over 40% of American adults that do have a BMI at or equal to 30. And then the last category is a BMI at or equal to 40, where we have almost 10% of Americans meeting that definition. So what really is striking here is that if you do the normal thing that everyone does in America, you're going to have challenges with excess weight. It's not that 75% of our population has all of a sudden become lazy, or that 75% of our population just lacks willpower. If you do the normal thing that everyone does, you're going to have challenges with being able to control weight. And then you can see how this has changed over time in the graph on the right. And really taken off over the last decades. And if you look back even further, you see an even stronger growth trend. And you can see that top line is the trends in prevalence of obesity, and that bottom line is trends in prevalence of severe obesity. And that's that BMI at or greater than 40. And these data are taken from NHANES, where I worked for a year and a half, and these are our national surveillance data. These are measured data, heights and weights that are measured. A lot of the data that you hear related to weight is based on self-report, and you can imagine there's difficulties with being able to accurately self-report on height and weight. So obviously this is a challenge for most Americans, the very large majority of Americans, and kind of flips the script a little bit on the tendency to blame an individual for their medical condition. And you also see differences by sex and race and by many other demographic characteristics. I've just got sex and race here because you can see some of the very striking differences in prevalence of obesity, where you can see the lower levels of obesity among non-Hispanic Asian populations, and higher levels of obesity, particularly among non-Hispanic Black women at almost 57%. And so you do see differences there related to a lot of the social determinants of health that we're going to talk about, and many of the other factors where populations from a racial and ethnic background are seeing more challenged health conditions, more negative health outcomes. And obesity is really underlying a lot of those health outcomes. So we're gonna dive into that too. That's what's here. So we know a lot of the more familiar consequences of obesity are the metabolic consequences, the increased risks of type 2 diabetes, high blood pressure, stroke, several different types of cancers. You've got your coronary artery disease or peripheral artery disease, heart failure, atrial fibrillation, polycystic ovarian syndrome, and chronic kidney disease. And those are just some of the metabolic complications. And those tend to be the ones that we think about as being related to obesity. But there's also mechanical complications, and these are related to the excess weight that the body carries around. Some of these non-metabolic complications, such as obstructive sleep apnea. And this, of course, leads to many other health effects down the line. GERD, that reflux disease, arthritis, adult onset asthma, gallstones, and these are non-metabolic consequences of having the condition of obesity. And of course, mental. So we see well-being and health-related quality of life being lower with people with obesity. There was even one study with children that showed that children with severe obesity had a very similar quality of health-related quality of life as children with cancer. So a lot of this is related to the stigma that we're going to talk about. And mental, of course, is one area where we see those bidirectional relationships very clearly between obesity and some of the mental health challenges. So we kind of talked about how common it is. We talked about health consequences, a little bit about how we define obesity with BMI, which is not the gold standard measure. BMI is an estimate of obesity because obesity is actually excess adiposity that impairs health. And so it's really the percentage of body fat or the percentage of adiposity, which you can only get from a gold standard of a DEXA scan, and a discussion with the doctor related to how that condition may or may not be affecting your health in order for you to really be able to have a diagnosis of obesity. So BMI works well for screening, works great at the population level and kind of for understanding trends. But for an individual asking themselves, do I have excess adiposity that impairs my health? That's a very personal discussion with that person and their doctor, and something that the doctor is able to make a decision on based on those health consequences, as well as other characteristics related to how the adiposity is distributed, and the other health consequences of it. So keep in mind, a lot of the research related to obesity is using that BMI as a screening tool, which does work well in research studies and it works well at the population level. But again, is not so great on an individual level. So there are certain populations where BMI especially doesn't work well. For example, athletes. Athletes have a lot of muscle mass. And so their weight for height ratio, which is what BMI is much higher. And they don't actually have excess adiposity a lot of times, even though their BMI would put them in that category. Another example where BMI doesn't work quite well is Asian populations, and they actually experience negative health consequences related to obesity at much lower BMI levels. And so the cutoffs for diagnosing obesity with Asian populations have been lowered because of that. Elderly individuals with sarcopenic obesity, that's another population where BMI tends to be not a great measure. So keep in mind, if you're thinking about, well, how does this apply to me? Then that's a discussion to have with your doctor. And understanding that BMI is a research tool, is a population health measure, it's a screening tool. It's quick, it's cheap. You can go to a calculator and online and put it in right now and find out immediately. But then if you find out that you do have an elevated BMI, then that's the time to talk with your doctor about, is this level of adiposity affecting your health or likely to affect your health in the future? And so we see obesity has been described as a chronic disease across numerous medical societies. there is really broad consensus in the medical field that obesity is a chronic disease. And this can be contrasted with what we often hear, which is obesity is your failure. It is your lifestyle choice. It is your lack of willpower. Your weight is your own problem. It is yours to figure out. And so that reflects the stigma that we're going to talk about today. And it is in contrast with how the medical societies agree that obesity is a chronic disease. So you can think about it similar to other chronic diseases that we're very familiar with, like high blood pressure, like high cholesterol or high triglycerides, like diabetes. Those are chronic diseases. And so for obesity, it's a chronic disease where the systems that regulate our energy are off, they're dysregulated. Just like with diabetes, the systems in your body that regulate glucose, the amount of sugar in your blood, are dysregulated. So we can think about the chronic condition of obesity similar to how we think about hypertension, high cholesterol, diabetes, and many other chronic diseases. And we should treat them medically like we do other chronic diseases. Again, this is a disease where energy itself, the systems in your body that control how much you eat, control your metabolism, other things, those systems are dysregulated, they're off. So how is appetite regulated? If it's not just my decision to eat, that's one component of it, but it's much more complex. Appetite is regulated through 3 different pathways in the brain. And I'm going to start with homeostatic. That is our appetite being regulated by hunger and satiety cues, hormones in our bodies. So you've got your main hunger hormone is called ghrelin. I remember it, ghrelin is grumble. It's produced by your stomach. It makes your stomach grumble. You're hungry. And so we've all been in situations where we feel like we are so hungry that we could just push someone off of a bridge so that we could get to a bag of Doritos. Like we've all experienced, and that's like homeostatic hunger. That's a hormone signal in your body that your brain is interpreting and telling you that you're hungry. And then you have the combat, the opposite of that is your satiety hormones. There's many of them. GLP-1, PYY, CCK, even leptin, which is secreted by your adipose tissue, is a signal that your brain interprets for long-term energy stores. So these signals are secreted by your stomach, by your gut, and then they travel up to your brain, and in your hypothalamus and your arcuate nucleus, it stimulates these hunger. Ghrelin will stimulate the hunger pathway and inhibit your satiety pathway. And then your satiety hormones do the opposite. So that's when you first take that bite of food and the food gets down to your intestines, and then your intestines say, oh, nutrients. I'm going to secrete satiety hormones, your GLP-1 and your CCK and your PYY. And that's stimulated by nutrients, your incretin hormones, there's many of them. And then those send that signal back up to your brain to say, oh, I'm starting to feel full. I don't need to, I can slow down, I can stop. Those are your satiety hormones. And that's that homeostatic pathway, which is your hunger and satiety driven by those hormones. But as you can see, that's only one pathway. We all know that we eat for many more reasons than just being hungry and stopping because we're full. So we all have a great meal, we're satisfied, we're no longer hungry. And then what comes out? The dessert. And we're like, ooh, I'm gonna like that. And that taps into that hedonic pathway, right? And this is eating that is driven by pleasure, driven by that dopaminergic pathway that is accessed by many other activities that give pleasure. And that's a whole separate pathway that is our brain helping to regulate our appetite. And so all of us know what it's like to eat because we want something, not because we're hungry or we're full. But what gets emphasized the most in societal discussions about excess weight is the executive function pathway. So you may not be hungry. You're not feeling that sense of hunger. You've eaten maybe a couple hours ago. Maybe you've already had your dessert, or maybe you skipped. So you're not feeling that hedonic dopaminergic pathway. But maybe you say, oh, it's 6 o'clock, time to eat. I'm going to decide to eat. So that's that executive function. Or one example I like to say, I went on a hike this summer and I wasn't particularly hungry because I had just had a big meal, but there was an extra banana in the car and I knew that I was going to be hiking for 4 days. And I'm like, bananas are good, but it's not activating my hedonic pathway here. But I'm like, I'm going to be hiking for 4 days. I'm going to eat this banana, even though I'm not hungry. It's not activating my hedonic pathway. I am using my executive function to say, I'm probably going to have a deficit of calories the next few days. I'm going to go ahead and eat now. And this is the pathway that gets really emphasized a lot when people are talking about weight, because they just say, well, you need to eat less, or you need to eat healthier. You need to decide to do this. You have to overcome your biology and all these ways that your brain tightly regulates your eating and your metabolism in order to lose weight. And as you can see, that is just overly simplistic. Our brain is really driving that biology. And what happens when someone with obesity does lose weight? We actually see your body respond to defend that adipose tissue. And so when you increase your physical activity and you decrease the amount of calories that you're eating, your body says, wait a minute. It gets to a certain level and your body says, no, 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 no. This is a threat. I'm not supposed to be losing weight. And so it actually, at some point, will decrease your metabolism. It decreases your resting metabolic rate. You're eating less, so the amount of calories burned through the thermic effect of food, and that's just the amount of calories that that are burned because of the process of eating food, but you're eating less food, so you're having lower thermic effect of food, and it's picking up on that increase in activity, and it's saying, wait a minute, I need to conserve calories. So it slows your metabolism down. That is unrelated. You can't control that. That is your biology actually defending that adipose tissue. It's fighting back against weight loss. So that's the metabolism side. The other side is that your brain starts having these hormone changes, that it starts increasing your ghrelin, your hunger hormone. So your ghrelin levels go way up. And then it starts decreasing your satiety hormone. So your leptin, your GLP-1, your PYY, CCK, those hormones get decreased. And this is your body reacting against your efforts to lose weight. So you feel hungrier, your metabolism has slowed down, and you have that one piece of pizza and you're like, I'm just not full. I need another one. I'm still hungry. I don't have that satiety. And that is the biology behind weight, most of which is not in your control. So it really is overly simplified and not accurate when we blame an individual for their inability to eat so little or exercise so much to be able to lose weight. And that is where a lot of this weight bias and stigma comes from. We socially devalue people because of their body size. It's one of the most commonly behind, obviously, race, gender, and age, is the fourth most common type of discrimination is related to people's body size. And you see people with obesity and severe obesity or different levels of excess weight, between 20 to 42% of them report that they have experienced stigma. So this is very, very common because we have this societal tendency to label weight as an individual choice and not understanding the biology that's behind that. And this leads to a whole number of negative physical, emotional, even economic. People with obesity are less likely to be selected for especially front-facing positions. So think about, let's see, your hotel concierges and front staff and wait staff, those public-facing roles. People with obesity are less likely to be hired into those roles. People with obesity are more likely to receive lower hourly wages, especially women. Women really do have higher levels of weight bias and weight stigma. And then the social judgment, where individuals feel blamed that they are unable to control their weight. And it leads to a whole host, oftentimes, of many other issues, including the care that people with obesity receive in our healthcare system. Physicians have been documented to spend less time with patients with obesity. Physicians will rate people with obesity as being more lazy or non-adherent with treatment. And they tend to, they oftentimes will see someone's weight, and it might be the only thing that is kind of commented on. So I was talking about this actually just a week or two ago, and a woman told me, you know, I don't like going to the doctor because every time I go, they just tell me that I need to lose weight. And they just say that I need to eat less and move more. And she went in with knee pain. And she said, I could barely walk. I was walking with a cane. I went to go see an orthopedic doctor, and he just told me to lose weight. So she left, went. Weeks later, a friend, she was still having so much pain walking, and a friend said, I really think you need to go see someone else. You can barely walk. This is not just, this is something unusual for you. And she ended up going and got a second opinion, and she had a torn meniscus. But that provider saw her weight, heard that she had knee pain, and just automatically said, you need to lose weight. So oftentimes when people with obesity go in for care, that is a predominant factor that the physician sees, and can hide other issues that a person may be experiencing with their health. So this number here came from a study of medical students, and they actually had a virtual patient that was complaining of shortness of breath, a virtual patient with medical students coming in saying they experienced shortness of breath. Obviously a very serious presenting condition that we would hope physicians would treat very seriously. And if the person had obesity, then 54% of the medical students just recommended lifestyle changes for shortness of breath, compared to only 13% if the person did not have obesity. That provider, that medical student did not talk about lifestyle changes when they had a presenting complaint of shortness of breath. And so, as you can imagine, this leads to differences in care that people have been experiencing. And even though I do think the healthcare system is getting much better now about recognizing weight stigma and learning about the biology behind obesity, even if the physician is aware, this has been the history of many people with obesity experiencing that discrimination in the healthcare system repeatedly, avoiding care because of it, and then getting, just unhelpful advice to eat less and move more. It's like, thanks, doc. I haven't tried that. I haven't thought of that. So it really has a lot of wide-ranging effects, including ACEs. So I know in this group, a lot of you are studying ACEs and thinking about the consequences of ACEs. And we definitely see that relationship with excess adiposity here. Prevalence of BMI over 35 just increasing almost linearly with the number of ACEs that individuals experience. And you can think of a variety of pathways for this, right? You can think of stress pathways that are maybe more direct and biological, as well as indirect pathways related to economics and other social determinants of health that we know impact both ACEs as well as obesity. So I hope by now it's very easy to see that obesity is very complex. So now we understand what it is, we understand health consequences, we understand some of the weight stigma attached to it. So what do we do about it? And this is where I'm going to take you on a journey of my career, because I inadvertently have kind of worked in almost all of these domains at one time or another. And so we're going to take a journey through some of the different interventions and prevention methods that I have worked on throughout my career in preventing and treating obesity. And the first, I'm a clinical health psychologist. And so I definitely have done my fair share of behavioral interventions. And for a long time, this was really, it continues to be even the mainstay of treatment of obesity. So on average, a behavioral intervention, and this is where you're getting professional support on how to decrease calories and increase physical activity and behavioral strategies to overcome a variety of things in your environment. So kind of the common forms of behavioral intervention yield 3 to 5% weight loss. And these are your evidence-based interventions, your evidence-based treatments. And so typically, these are 20 to 50 contact hours a year. And that's the bar for evidence-based when it comes to behavioral interventions for weight loss. This is, what do you think happens in the healthcare system normally? Maybe you see your doctor once a year, twice a year, maybe you meet with a dietitian twice. It doesn't really, most of the time, our healthcare system can't provide this higher frequency of care. And physicians rarely even have training in how to treat obesity. So there's a lot of myths and misconceptions here. One of my friends who's currently trying to work on losing weight after having a baby said, yeah, I went to my doctor, I'm trying to lose weight. She had preeclampsia, so she was having high risk. And she said, yeah, my doctor just told me that whenever I was hungry to drink a glass of water. Well, that's not evidence-based. In fact, we've done studies on that. And just drinking a glass of water when you're hungry as a randomized treatment doesn't yield any additional weight loss. So there's a lot of just personal advice out there that is not evidence-based. But even if we do have the tip of the top line Cadillac intervention of behavioral treatment for obesity, on average, you're going to get 5% weight loss, 6% weight loss of your body weight. And that is, not something to shake your head about. 5% can lead to reductions in blood pressure, improvements in triglycerides. So it is considered clinically meaningful. But oftentimes we see even more health improvements with greater levels of weight loss. So for example, if you have obstructive sleep apnea, you really need at least 10% weight loss in order for that obstructive sleep apnea to improve. So in the common forms, you're going to see oftentimes below clinically meaningful levels of weight loss. And then it's rarely sustainable. So the problem is less that we don't know how to get people to lose weight. The problem is a bit more that defense against weight loss, right? The problem is that weight regain. And we have a much more difficult time with weight loss maintenance because of the biology, right? Fighting against weight loss. So we all know people that have lost weight, and then we see them how many months or years later, and they have regained that weight. And it's not because they quit trying. It's not because they're failures. It's not because they, don't have enough willpower. It's because there is that biology where almost everyone regains that weight. 80 to 100% of weight is lost through behavioral interventions is regained in 5 years. So 50% of people regain everything. So it's rarely sustainable, and it's not because of a willpower problem, it's because of that biology. Not everyone, right? There are those 2-pack-a-day smokers that quit cold turkey the first time without any help, but that's not the average. And that's also the case with obesity. There are people that can lose large and clinically meaningful amounts of weight loss with behavioral interventions, but that's really not most people. And our society sees this and rewards this and really values, we put on a pedestal those people who were able to lose large amounts of weight just through changing diet and exercise. And it's really uncommon, very, very uncommon. So I've worked in a variety of behavioral interventions. At some point, they all end up impacting the individual, whether I'm doing direct dietary counseling with patients or working on physical activity with patients, or whether I'm working on a school breakfast program, trying to understand how school breakfast impacts weight in kids. That was another one that I did. And in an urban setting, we actually saw that a classroom breakfast program actually increased the rate of obesity among children, because especially those with overweight, those were the ones that they were getting an additional meal many times put in front of them during school at the beginning, and it increased the rates of obesity. Now, that was in an urban setting, but it does, make you take pause that we have to be cognizant of how we want to go about helping folks with healthier behaviors and thinking about possible unintended consequences. I've also worked on community events. So I worked on a big trial in Philadelphia that looked at installing hydration stations to replace these old yucky water fountains that no one wanted to drink from. And so let's improve the environment. Let's make the healthy choice the easy choice. Let's make water appealing. And at the same time, we had a beverage tax that I'll talk more about in an effort to change the environment to help people be able to more easily lose weight or more easily eat healthier and increase physical activity. So I've also worked on surgical interventions, and this is actually considered one of the only maintainable ways for weight loss. But there is this stigma that it's the easy way out, when in fact, it's correcting that biology. Your gut hormones change after you have surgery, and this leads to large amounts of weight loss, rapid, dramatic improvements in comorbidities. A lot of people with type 2 diabetes, it remits. And there's a range of types, but still fewer than 2% actually receive surgery, even though they're eligible. So surgery is a great option in terms of treatment of obesity. As a psychologist, I've worked with many patients who were preparing for bariatric surgery and going through that evaluation process. And you hear from them firsthand how they have tried everything. And it's not the easy way out. It's very much a tool to correct the biology. So again, we keep coming back to this. Obesity is complex. That was some of the individual level interventions that I worked on, even related to behavioral factors. And then I said, well, let's try something different. Let's try prevention. Let's try working on policy. Let's try working on the environment. So after I did my postdoc and my clinical internship working on behavioral interventions and surgery, then I went into public health and I said, I'm going to start with prevention and I'm going to work on policies in the environment, moving to the other side of this system here. And so these are a variety of the policy interventions that I worked on. We ended up passing regulations to limit the amount of juice that was served in early child care education settings. One of our big achievements was the sodium warning label legislation and the beverage tax I'll talk more about. And then we had a lot of public health media campaigns where we were trying to get make the free and safe and available ways to be physically active kind of more top of mind in Philadelphia, and work to improve access to free and safe ways to be active. And then I mentioned the water access intervention that we did, where we went into recreation centers in low-income neighborhoods in Philadelphia and made drinking water much more appealing. We saw a doubling of water intake at those water fountains, those hydration stations. So these were policy interventions that I worked on. Very exciting. The biggest probably policy that I have worked on in terms of obesity prevention is Philadelphia's sweetened beverage tax. And so we published a study in JAMA on the outcomes of the Philadelphia beverage tax using chain retailer sales data. So you can buy this from a third party, and it's all of your supermarkets and your box stores and your pharmacies that sell their cash register data. And then you can analyze that and see after the Philadelphia beverage tax what happened, and compared to surrounding counties, compared to similar cities without a tax. And we found this, that even accounting for a slight increase across the border where there wasn't a tax, overall there was a 38% drop in the purchase of beverages that were covered under the tax. So this was a major public health policy win that was very exciting to work on, and showed very, very dramatic decreases in the purchases of sugary beverages, sweetened beverages. And this was either artificially sweetened or sugar sweetened. So this was a major policy that went into effect the first year that I was at the health department there working on the policy side. Another one we did was legislation to require a warning label next to any menu item that for a chain restaurant that contained more than an entire day's worth of sodium. So 90% of us consume too much sodium. Of course, this increases risk for hypertension. And the big chunk of that comes from restaurants, 25%. People, when they think about cutting sodium, they say, oh, I don't put salt on my food. In actuality, only about 6% of your sodium comes from the salt shaker. So it's really a very small percentage of sodium intake if you just cut out the salt shaker. Really, you want to go for those processed foods, those packaged foods, those restaurant foods. That's where the large majority of our sodium comes from. And so we actually worked to scientifically test the design of the label. At the time, New York City also had a sodium warning label law, and they had this little triangle that you can see here on the bottom left with the salt shaker inside. And it was only that icon, and that was all that they had. And so we said, well, I don't know if people know what that is. So we actually did some randomized online experiments to test different label designs. And we were actually able to use that data, which showed that with the warning label, we could help people can hypothetically order 1 to 12% less sodium from restaurants, and that the words sodium warning were particularly important for people to understand what that was. And so we were able to use these data to put in the legislation more specific guidelines around sodium warning labels. So here I was at the health department working on beverage taxes and sodium warning labels, and then COVID came. And obviously this was the front lines of working on the pandemic, and I will take a little sidetrack in my career here because I spent the next 2 years working on COVID-19. And this was where I had the privilege of leading a team of amazing contact tracers that did everything from contact tracing to testing to vaccine clinics to just anything that needed to be done to serve the city that we lived in that was getting hammered. I mean, we all got hammered. This was a very difficult time. So I did this little side track, which wasn't the first time. I actually noticed there were a lot of similarities in something else that I had previously worked on, which was the Ebola epidemic. And so I was struck by when we saw the Ebola epidemic happening, and we were so quick to blame those individuals who had a lot of these misconceptions about how to handle burials and hand washing and a lot of this. And I went out to Sierra Leone and tried to work on getting people to change some of those misconceptions and access treatment so they would be able to stop spreading Ebola. And there was a lot of resistance. And of course, we saw a lot of resistance and controversy around the pandemic response here. And so it was a very interesting experience for me to be working on an emergency epidemic response in Africa, and then a few short years later coming back and then working on the COVID pandemic response at the Philadelphia Department of Public Health. And little did I know, this in turn would link back to my career in obesity. And we saw one of the biggest risk factors for individuals with COVID-19 developing severe disease was excess weight. And so you can see here the risk of actually being hospitalized from COVID-19 increasing with increasing BMI. So again, this links back to a lot of what I've been working on in my career of prevention and treatment of obesity, albeit in a very different way. So again, we're back here from being reminded about our complexity. I've worked on the behavioral interventions, the community interventions, the policy prevention options. And I said, I'm exhausted from the pandemic. I'm going to get back to chronic disease treatment. And the next step in my career was joining Novo Nordisk. And this is where I learned much more about the biology, learned that there were medications available that were more effective. So on average, we see between 6% and 17% weight loss with the 6 FDA approved options that are available by prescription. And they really target that arcuate nucleus, those pathways in your brain that are regulating your appetite so that you're able to reduce your intake. It doesn't magically burn anything or do anything in magic. It actually works on those appetite regulation pathways. And there's so much happening around obesity medicine that this was an exciting time. So that leads me to where I currently am to this day. I'm in the medical side of the company. So I don't sell things, which is nice. I think that would be difficult, but my job is really to talk about the biology behind obesity, to talk about the stigma related to obesity, and whichever treatment is medically appropriate, whether that's behavioral, whether that's surgery, whether that's medications, whether that's something else, a combination. That's what we just want for physicians to be aware and for obesity to be taken seriously as a chronic disease. So we've talked about both treatment and prevention options. And they're often discussed interchangeably, and they sometimes are pitted against each other, but we know that it is so complex, we really need both. We just have to be careful that we aren't expecting treatment level results from prevention intervention. So our healthy behaviors, our policies that are working on promoting healthier environments, those are prevention options, and those are critically important. I've spent most of my career working on those. We just need to make sure that we're also thinking of how can we help those individuals that already have obesity, that already have negative health consequences from obesity. So both of them are critical, and we can't expect some of the lower level interventions targeting healthy lifestyles to really produce clinically meaningful weight loss. So how might this matter for you? Hopefully you've heard some morsels in the talk today that help you think about how, obviously many of you are going to be interacting with patients with obesity, understanding what they might be going through, understanding it as a chronic disease. Behaviors still matter for all of us. All of us, it's important to have those healthy behaviors, whether we have obesity or not. And understanding this tie between our physical and our mental health, as Dr. Dixon mentioned. And you can think about talking about this and encouraging strengths-based approaches with patients and thinking about those positive behaviors, and then also referring when needed. So if you're doing research with patients, anything like that, and these are resources depending on whether you're a patient yourself, whether you're a provider or hospital thinking about how to treat obesity. Researchers, we need to be especially careful of how we use weight and BMI data. And so David Friedman and Christina Lewis have a lot of publications on this, on how to use weight and BMI data. If this talk has inspired you to start looking at heights and weights in your program of research. And importantly, making sure that we're using person-first language. You heard me throughout today talk about people with obesity. We should kind of strike the word obese from our vocabulary and think about people first. We don't call a person with cancer cancerous. So we need to think about person-first language to reduce stigma and not make assumptions about someone based on their body size. And then you can see a number of other resources here, depending on which one of these buckets you fall into, that hopefully can help you think about ways to incorporate this into your work. And again, we're about to go enjoy Thanksgiving. I wish you all the happiest time with your loved ones. That's why I'm back here in Tennessee, so that I'll be able to go enjoy Thanksgiving with my loved ones without any stigma related to what anyone is going to be choosing to eat, and making sure that we're not perpetuating any of that stigma and bias. So I went a little longer than I had wanted to, but we still have 10 minutes for questions. And I've got my email here if any of you do want to follow up and have other questions later. And then I think Ben's going to help me with Q&A. I can also look here, but. And then I guess I can stop sharing the screen now.
Yeah, there was a chat that came up. Number one, I just want to thank you, Dr. Lawman, for coming. This was great, and it was very informative, and we're just feel privileged that you could come and speak in person. It was nice to meet you. So I have a few questions myself, but I should probably let other folks. There was one that came up. This seemed like a question potentially for a philosopher, but there was a question here about the just world theory. I'm not sure if you know what that is. I did a little research.
Okay, I'm not familiar with the just world theory.
So there's a relationship. People think there's a relationship between how you are as a moral actor in the world and then outcomes. So if you're a good person, then good things will happen to you. So I think they're trying to get into the psychology of, I'm a good person, why am I being overweight? Or if this person is overweight or obese, then maybe they're not being a good person. And does it have any kind of relationship with outcomes in terms of therapy and stuff like that, or interventions? Again, that seems like a question more for a philosopher potentially, but maybe you have some comments on that.
Yeah, so I'm not aware of any research on the just world theory with obesity, but what I am aware of is that when people experience stigma, if they're blamed for their weight, we see that associated with even worse outcomes of actually treatment of obesity. So I don't know if the just world theory applies that same kind of logic to any other negative outcome. Like, you know, a lot of it, we've all experienced negative outcomes, but I really like to go back to obesity should be treated just like any other chronic disease. So are you going to say the same thing about somebody with hypertension? Are you going to say the same thing about somebody that had cancer? So I don't think obesity should be treated any differently. And across the board, across a variety of negative health conditions, we see stigma is problematic and leads to worse outcomes. So that's all I can say about that, not being a philosopher, but definitely an interesting question.
And there was one more. Yeah, good things happen to people that might not be nice and the other way around, you know?
Right,
So,
exactly.
yeah, there was a question there. too.
Okay, so here, speech language pathologist, grad student. Glad to hear you're interested in thinking about gut microbiome and cognitive function. Understanding of how a Western diet might be causing a larger risk of population developing Alzheimer's. So do you have any recommendations or specific studies or resources I should look at for this topic? So we get this question a lot of what's the best diet? What's the healthiest diet? What's the best diet? Maybe it's related to weight, maybe it's related to Alzheimer's, other things. With weight, we tend to see that whatever diet you're able to stick to is the best diet for you. And so when we randomize people to do, let's say, Mediterranean diet or a high-fat diet or a low-fat diet over 2 years, we don't actually see meaningful differences in the amount of weight loss over 2 years. And a lot of that, it is very difficult to adhere to these because of the biological mechanisms that we talked about. I'm not as familiar with dietary outcomes related to Alzheimer's in particular, but we do see relationships with obesity activating the inflammatory pathway, being linked to a variety of other conditions. So there is research ongoing looking at some of the treatments for obesity in Alzheimer's as well. So that's interesting. So I would think there would also be underlying biological mechanisms to be thinking about in addition to the dietary pattern. So not too much. Hopefully that helped a little bit, but okay. What are the side effects of obesity medicines? What are the names of some of the medications? So because my day job is talking about this regularly, I am not able to answer this question kind of publicly here, but I can talk, I guess, a little bit about some of the side effects vary on medications. But if you email me, I can answer your questions privately. That's a response I have to give for Novo Nordisk. I'm not supposed to talk about specific medications when I'm here on my personal time. But you can Google FDA approved medications for chronic weight loss. The National Institutes of Diabetes and Digestive and Kidney Disorders also has a great resource that gives an overview of all of the FDA approved medications. So I can direct you there, and they have a very comprehensive overview of the side effects and gives you both the brand names and the specific the molecule names for those medications. So if you do want to talk more about the specific medications of obesity, I'm happy to do that. We just have to do it in a professional setting for that. But great question, and does kind of get us thinking about those underlying biological factors. Dr. Dixon.
I have to repeat this question in the mic, but I recall you telling me when you were in Sierra Leone that some people thought they got the virus from riding in ambulances, when in fact, of course, it was the reverse. Did you, as the lead in Philadelphia with COVID, did you run into sort of irrational behavior or thoughts, or I wonder if people thought that that getting a vaccination caused the disease, that kind of thing.
Yeah, so Dr. Dixon was reflecting on some of the stories I talked about from my time in Sierra Leone, where people had thought that because their loved ones went away in ambulances and never came back, that ambulances was what was giving people Ebola, and asked if there was any similar kinds of concerns around vaccines in Philadelphia. And I'm sure we all experience this. We saw this all over I have heard that. I don't have a specific story in Philadelphia. I think in Philadelphia, vaccine uptake was rocky at first, but then ended up being pretty well. But I think there's a whole number of misconceptions related to vaccines that all of us saw, that they were tracking you, or that if you got vaccinated, that you could then infect someone else. And so that kind of is a similar misconception that we saw around vaccines, and there was just a whole host of misconceptions there. So definitely that was one of the parallels that I saw when I was working on the COVID vaccine in Philadelphia, or COVID epidemic in Philadelphia, in a variety of ways, and kind of made me remember some of those misconceptions that I encountered when working on Ebola in Sierra Leone. Yeah. There's actually a really excellent podcast where I think it was This American Life, and it was her story of her brother who got COVID, and the cousin was saying exactly that the brother contracted it because he gave someone who was vaccinated a hug, and the brother unfortunately ended up dying, and it was very, very sad. And so she was trying to provide medical reputable medical information. And then there was this cousin that was saying, no, you got it from someone that was vaccinated, and that's how you caught it. And so it was a really interesting story that made me think of that when your question came up.
Did you say you had a question?
I would love to ask.
Yeah.
Yeah. So I'm a public health person, so I'm thinking about non-therapeutic modalities in terms of pharmaceuticals that might have been able to be scaled up or have been observed to scale up in terms of the general population. I know there's a lot of individualized attempts to help people like your lifestyle, but I was curious if there's any interventions that work in terms of scaling up, like for the aggregate of folks that are dealing with obesity. Does that make sense?
A little bit. So is your question, you're asking about maybe a public health approach to pharmaceutical treatments?
No, non-pharmaceutical treatments.
Oh,
specifically,
non-pharmaceutical.
like interventions that might work and are scaled up and are efficient in terms of reversing outcomes, but also like resource expenditure, so that you don't have one doctor working with one person. You might have a programmatic intervention kind of thing.
Yeah, so this is where we get at a lot of the community and school-based interventions, and most of them don't actually see measurable reductions in obesity per se. A lot of them see increases in fruits and vegetable intake, and increases in water, and reductions in sugary beverages, and increases in physical activity. And so those are great. We want to see those healthy behaviors improving, and a lot of those behavioral interventions that we scale up at the population level are effective in improving health behaviors for the broader population. But this gets back to my comment around prevention versus treatment. And so I think public health is more in the realm of prevention, and a lot of those behavioral interventions that you're working on are effective at preventing, maybe preventing progression. I don't think the research is very strong on there. But when you get into treatments, when someone has obesity, that's where you need much more targeted, very intensive behavioral interventions, 20 to 50 contact hours a year, in order for you to actually see reductions in BMI, excess adiposity, body weight.
Prevention is the gold standard.
Yes, prevention is the gold standard, but remember, there's 42% of the population that already has obesity. So we can't just forget about them. I'm 100% on board with prevention. I've spent so much of my career on it. I love that. I want us to all be in a healthier environment and have healthy behaviors more easy. But I also want us to remember that having obesity and not having effective treatment of obesity leads to all those health consequences that we showed early on. And so we still have to help them.
Well, I would ask another, but I think we're at time here. So I'll ask you after we finish. Well, do you want to close out, or you want me to close out?
Thank you.
I was just gonna, yeah.
Thank you.
Thanks everybody for joining us, and there'll be a survey to give us some input that should populate to your browser at the close of this Zoom session. And thanks for coming out. We really appreciate it. If you have any questions, you can reach out to Dr. Lawman directly, or you can always reach out to me and I will connect to you. And I'm sure I'm gonna get some questions about your slides. I'll put them in a PDF as long as Dr. Lawman's okay with that and send them out. So thanks for joining us and thanks for coming today. Really appreciate it.
Thank you for having me.